All right, so let's move to diagnosis and treatment. And Jessica, I'm going to start with you on this in terms of how to diagnose IBD. Again, a topic that we could probably spend several hours, but in terms of how do you look at symptoms, blood work, imaging, endoscopy, kind of give us your overall approach to diagnosing IBD.
Sure, absolutely. And so as you mentioned, you're going to be using a whole host of factors when you're working up a patient. There's not just a single test that says this patient has IBD, so it's important to remember that. And so always start with a good history. You know, you want to be asking your patients about diarrhea, rectal bleeding, urgency, tenesmus. Are they waking up from sleep to have bowel movements? All of these sort of clinical clues that there's a more organic process going on. Certainly signs of obstruction, distension, vomiting. And then I always ask about potential signs for fistula complications. Are they having air in their urine or air passing from the vagina? Things that patients might not even think to tell you. Certainly when you are doing laboratory assessments, you're looking for signs of systemic inflammation, CRP or ESR, as well as signs of anemia, generally speaking. There are other lab tests that people can use. There are the P-ANCA and P-ASCA assays, which P-ANCA has been associated with ulcerative colitis and P-ASCA with Crohn's disease. I can tell you in my own personal practice, I don't tend to rely on these assays when I'm distinguishing ulcerative colitis from Crohn's disease or working people up, but they are available. I don't particularly find them helpful. I use sort of everything else we're talking about right now to make the diagnosis. I think the most important, though, is once you have a patient where you are suspecting IBD based on what we've discussed, is you need to do a full endoscopic exam. And that includes a full colonoscopy with TI intubation to really get an assessment of the small bowel as well. Because you really, before you start treatment, you really do want to stage this person. You want to know where is their inflammation, how deep are those ulcers, as we have already been discussing. But I always conclude with imaging of the small bowel as well. I really want to ensure that I know exactly where this person has disease to craft the best treatment strategy for them, whether that's with MR enterography or CT enterography or some of the ultrasound techniques that are emerging. But once we put all of that together, radiology, laboratory assessments, as well as clinical findings, then you're really able to make the diagnosis.
Right. So obviously a history and physical, and then a multimodality approach to diagnosis. And Marla, maybe moving to you for a differential diagnosis. So obviously the group on the line here are all at tertiary referral centers, but often these patients, as you know, in pediatrics, see their pediatrician first, or in adults, the family doctor, the primary care, were referred to GI for general symptoms. What's your breakdown for differential diagnosis for somebody coming in where IBD might be on the list, but what other things do you think about?
I mean, I think one of the things to also note is that there's often a diagnostic delay for our patients being diagnosed. So I want to sort of feed off of what Jess was saying, is that she's asking for more classic alarm or red flag symptoms and signs, because that'll pivot, that'll move them to the front of the queue. But there's still a lot of patients with Crohn's in particular that have been told to change their diet, have been diagnosed as irritable bowel syndrome, to just, deal with it, take more Miralax, whatever is on the table. There's often a lot of diagnostic delay, sometimes up to 2 years in Crohn's patients. I think that's probably our biggest differential in terms of, patients presenting with some bloating, some fatigue, some intermittent loose stools, right lower quadrant pain, various bloating is one of the biggest symptoms that I think get attributed to IBS, for example. So I think that we're often trying to figure out, is this infection? Is this organic or functional versus non-functional? I think for colitis, typically infection is it's either, do you have an infectious cause of your bloody diarrhea, and name the list of the organisms that could cause that, especially if you've traveled recently or been exposed to antibiotics recently. And even in just having intermittent diarrhea without blood, that still defaults to an infectious cause. I mean, at the end of the day, when yes, there's a whole laundry list in our books of differential diagnosis, but let's be practical about what patients come to us being diagnosed as and where the biggest delay is. And so I think one thing that people underestimate is small intestinal bacterial overgrowth. I know it's not typically all over the map with our patients, but I would tell you that patients are often told they have some form of maybe IBD or IBS, and we're missing the fact that they've had, 10 courses of antibiotics for acne, or they've had, recurrent urinary tract infections, have been on multiple courses. And I think we're underestimating small intestinal or SIBO in our differentials as well. So I think it's, for us, by the time they get to us, they've sort of been through the gamut of differential diagnoses. I don't know if there's specifically something you want to go through a textbook of differential, but I think this is the most important two concepts that we often lose sight of.
Yeah, so we won't go through the medical school list of differential diagnosis. I like the way you broke it down. I mean, I think a lot of our patients are told they've had irritable bowel syndrome for years. I think that was a very important point. Celiac, small intestinal bacterial overgrowth. Some of these patients come in with infections, and obviously if it's an acute process. So I think those are probably some good highlights. We could get into ischemic colitis, diverticulosis, some of the others, but I think that's probably the good list, and oftentimes is what leads to a delay in diagnosing Crohn's or ulcerative colitis because they're assumed to have IBS. So David,
the other interesting thing about differential diagnosis is, Marla was talking about predominantly before you're diagnosed, but there's the whole differential diagnosis of symptoms after you're diagnosed, especially in Crohn's disease. And that also includes SIBO, it includes bile acid diarrhea, which you can now objectively diagnose, the liberal use of 72-hour fecal fat in patients who've had a lot of operations. And those things are often forgotten. And so you're not done with the differential diagnosis once the patient's diagnosed. It's not all inflammatory Crohn's.
Yeah,
I think you bring up a good point, because a lot of our patients, in a way, sometimes when we see patients in the office, we've done a great job at healing the mucosa, treating their inflammation, yet they're still having symptoms. And Bill, I think you kind of nailed part of the IBDology that we all see in our clinics is also the non-inflammatory part. So bile salts, fat, some other malabsorptive problems, vitamin deficiency. So yeah, no, I completely agree.